В ближайшие несколько минут я поговорю о ремоделировании потока в при эндоваскулярном лечении церебральных аневризм. Одно из важнейших достижений это лечение аневризм в точке бифуркации. И это произошло благодаря развитию поток-перенаправляющих устройств. Этот процесс называется ремоделирование или изменение перенаправления потока. Мы устанавливаем поток-перенаправляющее устройство в одну из ветвей, и, как показывают исследования в фоллоуапе, мы получаем разные результаты и разный уровень заживления повреждений. Если мы рассматриваем сложные аневризмы, установление поток-перенаправляющих устройств зависит от морфологии артерий, и при этом сохраняется проходимость сосуда. Иногда полное ремоделирование происходит через 2–2,5 года. Чаще всего все работает хорошо. Это аневризма ЗНМА, и мы можем изменить кровоток в этом месте и при этом провести окклюзию аневризмы. Это удивительная возможность, и при этом происходит реконструкция, изменение потока.
Trifurcation aneurysm in the right MCA, and the most superior trunk was pipelined, and this is the 6-month follow-up, and this is the 18-month follow-up. So the question is,
здесь вы видите лечение показателей через 6 месяцев и через 18 месяцев. Но у нас возникают вопросы. Вот здесь вот сохраняются какие-то остаточное наполнение аневризмы. Насколько это значимое наполнение? Здесь расслаивающаяся, разорвавшаяся аневризма, и в правой части мозговой артерии и мы окклюдируем сегмент А1. Этот случай, когда мы использовали первое поколение Silk в 2007 году, не разорвавшаяся аневризма задней нижней мозжечковой артерии, мы получили хороший результат, установили поток-перенаправляющее устройство, и получили хороший результат. Как мы сегодня бы лечили это повреждение? Я бы установил поток-перенаправляющее устройство в заднюю нижнюю мозжечковую артерию для того, чтобы сохранить полностью поток. И сегодня мы именно это и делаем. Мы используем эту технику. Это правая, это аневризма правого сегмента А1, которую удалось окклюдировать путем просто установления поток-перенаправляющего устройства. В этой части просто нет больше наполнения, и мы видим очень хорошую картину через 3 месяца, через 6 месяцев и через 18 месяцев. Уровень окклюзии 1С. Это значит, что это очень высокий уровень окклюзии.
So this was a ruptured icon.
Какая идея при этом должна у вас формироваться? Это сложная аневризма внутренней сонной артерии, которую раньше было очень сложно лечить, но благодаря новым устройствам мы просто изменяем направление потока и получаем вот такой хороший результат через 1 год. Полное сохранение потока в артерии и класс окклюзии 1А. Очень сложные аневризмы можно лечить с использованием этих устройств. В случае женщина 39 лет поступила.
Concept of intrasaccular reconstruction of the neck of the aneurysm thing, and he tried.
И здесь мы видим гигантскую аневризму на пересечении задней соединительной и среднемозговой артерии.
A flow diverter or stent stably in here. So even if it is possible, it was not easy. So then he just thought that what he learned from me, and he just deployed a flow diverter, couple of flow diverter, in front of the right PCOM artery at its origin, from P1 to P2. So just drop the flow from an advance. This is immediately after the aneurysm stagnated.
Сегмент P1.
This is before treatment,
и
this is after treatment.
Перенаправили поток, не было наполнения аневризмы больше, и здесь вы видите результаты до лечения и после лечения. И контроль через год, нету аневризмы, и при этом сохраняется проходимость основных сосудов. Нам не нужно делать какие-то сложные операции, маневры для того, чтобы лечить такие непростые аневризмы. И мы должны использовать другой подход, другую классификацию, которая бы соответствовала нашей реальности. У нас есть шкала Ренкина, и согласно этой шкале это полная окклюзия мешочка аневризмы. И в класс 1А это полная окклюзия с полным сохранением проходимости артерии. 1Б это полная окклюзия с уменьшением диаметра сосуда. И 1С это полная окклюзия с антеградным наполнением частичным, наполнением сосуда. И в эту классификацию нам необходимо добавить класс 5. Здесь вы видите пример окклюзии класс 1А. Потребность в сохранении кровотока здесь был не очень высоким, поэтому не полностью сохранился кровоток в данном сосуде, поэтому он уменьшился в диаметре, поэтому это класс 1Б. Здесь еще один пример.
But sometimes it shows an interval change. It did in this case. At 18 months, it started to refill antegrately, and with class 1B occlusion, because it's reduced in caliber. So sometimes this doesn't end with perfect reconstruction. This was a wide neck, right fusiform wide neck, right M1 aneurysm with a large temporal artery is coming off the aneurysm sac. So basically the pipeline is placed, as you see, at the neck, and this is a 1-year follow-up. See, aneurysm showed already some progressive reverse remodeling, and it just continues as a continuation of the vessel with a large flow demand, which is the right temporal artery. So 2 years follow-up, this is now we can call class 5 stable flow remodeling in the long run. As you see, we should not call this anymore as aneurysm remnant. So this misinterpretation especially happened in the posterior communicating arterial aneurysms where the embryonic peak comes off the aneurysm sac. So this misinterpretation led that some papers concluding that there is no indication of flow diversion in this setting. It's just not matter of flow diversion. It matters how much flow diverter are going to use there. So for large flow demanding embryonic peak arms in the ICA, it should be at least 3 pipelines. And this is 3 years follow-up, and this is 10 years follow-up. And as you see how there is such a reverse remodeling, so basically the PCOM becomes, the aneurysm sac becomes the continuation of the aneurysm sac. So this is something that we have to develop in our conceptually in our mind, that, and especially for PCOM aneurysm, so that misinterpretation is leading in the wrong places. So this is another large embryonic PCOM aneurysm, 3 pipelines, and 6 months follow-up. And don't expect to have a perfect reconstructive response here. The matter is if this aneurysm is going to bleed in long run or not. I never seen in the last 15 years. And this is 6 months follow-up, and this is 5 years follow-up, exactly same in the MR angio. This is the class 5 stable flow remodeling. So that experience built up and let us treat complex cases with unbearable simplicity. But of course, if we do the proper management pharmacologically, technically, and conceptually. So there was a question, so what we should do in bifurcation? So what we should do to give the time, especially with pipeline, we at least do use 0.5 millimeter oversizing according to the proximal vessel size. I just heard somebody ask to René Chapeau, okay? So we do oversize because most of these aneurysms are in convexity. So you increase decrease the mesh density a little bit to give a time to aneurysm to remodel, that vessel become the continuation of the aneurysm sac. So the importance of and especially MCA bifurcation is the chrome cobalt's geometrical modification effect. So the geometrical modification effect is so important for such aneurysms to have such flow remodeling, and again with nice class 1A occlusion in the wrong run with full patency of the vessel and occlusion of the aneurysm. So this technique, I'm very happy that some of my good friends and non-believers become believers to this technique. And this is a patient I got from Ishlak, my good friend. And look at the aneurysm. And very tough one. It's a multi-segment disease starting from bifurcation to extending into the superior trunk. All he gets to do is just to find the inferior trunk and place the pipeline. And look at this. At 1 year, this is class 1B occlusion with perfect reconstruction. If there is no flow demand, then that vessel may not be needed by the brain, as it happens in this MCA aneurysm with the superior trunk is dependent vessel. This is pre-op, this is 6 months, class 2, and this is 1 year follow-up. The vessel is gone, it feels retrogradely, not anterogradely, and aneurysm is gone too. So this is class 1C. But again, in some patients, you see in the follow-up, like in this left MCA with large inferior trunk integrated, you do DSA, and please don't jump on this. Hey, this is aneurysm remnant. This is not treatment success. We discussed this in some other meeting with a surgeon today. So they're asking for a complete treatment. I mean, what is complete treatment? The complete, we are chasing after a geometrical, perfect, artistic picture showing everything is gone. And you do the 3D, you realize that these aneurysms show a beautiful flow remodeling with such a simple treatment without just jerking around from the aneurysm and make a loop. I like to do this. I mean, most of this technique, you guys know, invented by me. I mean, we proposed the intraneurysmal loop technique and with a balloon, and we described that. I love doing it, but I very rarely doing it now because, I mean, the engineering bring this simplicity, so we gotta use it. Look at this aneurysm. Dissecting M1, trifurcation, very complex. The flow geometrical modification effect of the pipeline is needed here. This is 1 year follow-up. Is this a treatment failure? No, this is not a treatment failure. This is just a class 5 stable flow remodeling. This becomes the continuation of that particular branch which is integrated. It helps also the ACOM aneurysms. Look at this, the subcallosal is coming off the aneurysm sac. So our surgical colleagues that they perfectly know that these are the toughest cases because if you close this subcallosal artery, the patient is going to be a plant. If you coil this, when this is occluded, the patient is going to be plant again. So you just deploy a flow diverter. And look at this, 1 month MR angio, 6 month MR angio, aneurysm is gone. And this is a 1 year control DSA showing the perfect aneurysm occlusion with class 1B occlusion that subcallosal become a little bit reduced in caliber. And this was done, one of my fellows again, ACOM aneurysm, right A2 coming off the aneurysm sac. Very simple, left A1, left A2 flow diverter, the pipeline, I guess, placement. And before treatment, the A1 right side is hypoplastic, but 6 months later, not anymore. It's just the flow demand rearranged everything in the ACOM complex. The aneurysm is gone, right A1 got bigger and no longer filling from the left A1. But don't expect these results all the time at 6 months as we used to. This is wrong. This remodeling develops in a longer period of time in MCA bifurcation. You look at the 6 month control, is frustrated, the vessel is gone, aneurysm is filling, bad result, 12 months, vessel came back, aneurysm still filling, bad result, and 18 months, aneurysm is perfectly gone, and we have the new bifurcation. So I cannot emphasize enough that is very, very important to have an intensive and LTA controlled anti-aggregation for such progress, and that anti-aggregation should not be clopidogrel. If you had to use clopidogrel, then do treat this aneurysm either surgically or with some other things. And it develops in a longer time. As I said, again, another example, 6 months, don't get frustrated. 2 years, perfect class 1B occlusion. And this is the longest I ever seen from Jivan's case again with a Fred Jr. 3.5 years after treatment. They follow this patient with IV vaso-CTs. Aneurysm got smaller, 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 and finally gone. And this is the 4 years follow-up. So what it matters is just to protecting patient from a bleed, right? I have seen no bleed in the follow-up of these patients in the last, how many years? I don't remember now, it's 12, 13 years. So the long-term follow-up of such cases that with integrated branch, I think this MCA bifurcation has the largest number of serious we did with the Sharber's group, and we call actually 98% obliteration in the long run and with very low morbid mortality. with good anti-aggregation. So, however, if we keep calling, for example, this is the case we just did in the WLNC online last year. We discussed, and we decided to place a flow diverter pipeline. We need a geometrical modification. We did change the geometry, and this is just 1 month later. We don't have the 1 year follow-up in this patient because it was just treated in the course. But I'll bet you this flow remodeling is going to continue forever. So if we keep calling this as aneurysm remnant, of course, we don't say that 98% obliteration rate. Another one, 6 months, this patient had a ruptured left MCA. This is right MCA with integrated superior trunk, and 4 years. So I can show you like many of them. It happens for the web. Sorry about that, but we discussed this with many times with Laura and Piero. I hate this adequate or inadequate occlusion thing. I think we should call this class 5 stable flow remodeling. So if 2 or 3 consecutive angiography shows that same remnants, like in this MCA bifurcation, as Professor More showed perfectly, it just simplifies everything. Look at this. Look at the angles of the superior inferior trunk. It is hard to place the flow diverter. It is not easy to do the Y stenting, or it's not easy to do double balloon. I love doing it. I can do it if I deal with like 8 hours, but just deploy a nicely sized web and don't expect perfect anatomical result. This is 9 months control, and this is 18-month CTA. So this is class 5 stable flow remodeling. So guys, we gotta change our look to aneurysm occlusion. So the matter is, if we protect the patient from a bleed or not. So I hope we continue this in Shanghai face-to-face, because I'm tired of these Zoom meetings. Thank you very much.